the case 2-3 weeks ago. 2-3 weeks ago, your vasculitis, like glomerulonephritis. Very rare though. Post-renal causes also, if patient has a Foley catheter and is kinked, that's why you have to have good ICU nurses paying attention. Sometimes they call you, there's no urine output. You tell them, just flush the Foley catheter. They flush it, there's sediment obstructing the Foley. Or sometimes even the Foley catheter is in the wrong place. They have inflated the balloon within the prostate. And you can, if you have the luxury of having an ultrasound in the ICU, you can just bladder scan. You see a distended bladder. You know there's a problem with the Foley. Some patients also that have prostate hypertrophy, or rarely some obstructions of the ureter, or even a pelvic mass. These are not very common, but they are things to think about. By and large, most common cause for us intensivists is sepsis, or medications we are giving to the patients to treat sepsis that are causing, that is causing AKI. Briefly, I will just talk about sepsis and AKI. And this is mainly because back in the day, we all used to think it was hypotension that was causing ATN, acute tubular necrosis, leading to AKI in the ICU. But now we're finding out that it's not just a problem with the macro circulation, meaning hypotension. Because even sometimes, even when the blood pressure is normal or even high, patients still develop sepsis in AKI. And now scientists are finding out that it's a problem with the microcirculation, the microcapillaries. You have microcirculatory dysfunction, there's inflammation at the cellular level. You know, even when blood pressure is normal, they've done studies in large mammals and even humans. Now, when they did it in rats, they found out that, yes, renal blood flow dropped. When they did studies in humans and larger mammals, they found out that renal blood flow was actually preserved. So what else was going on? And this is where they found out that there was a problem right at the mitochondrial level, dysfunction, cell cycle arrest. And just hope you all can see this. I know the screen is small, but bottom line, what's happening here is that when cells are exposed to something we call PAMPs, PAMPs are called pathogen-associated molecular patterns. When cells are exposed to pathogens, our immune system leads to generation of PAMPs. Now, these PAMPs also now trigger cytokine release, and also you have DAMs. DAMs are damage-associated molecular patterns, and they all come together. You see these cytokines storm, all come together, causes microcirculatory dysfunction right at the microcapillaries in the renal tubules. And they all lead to AKI, damaging the kidney. Now, when this dysfunction is happening at the microcirculatory level, you have some cells called the pericytes. The pericytes are right here. They are right on the microcirculation, the capillaries. They are responsible for maintaining the structural integrity of the wall, preventing fluid leakage, edema, and infiltration of cells. But once patients have sepsis, even if the blood pressure is normal, it causes a breaking away of the pericytes from the wall. They're sheared off, and once that happens, infiltrative cells now move into the circulation because of leakage. All will cause hypoxia, and then eventually cell cycle arrest, tubular damage, and then AKI. You have all the problems that you see. So this is just trying to briefly explain what's happening at the microcirculatory level. So even if your patient has a normal blood pressure, but they have evidence of infection, sepsis, they can still develop AKI. How do we diagnose these patients? start with the simple things. You take a good history, do a good clinical examination, and then find out if the patient is retaining urine, bladder scan, check for Foley catheter patency, assess your hemodynamics, the volume status. Have they been exposed to nephrotoxins? You have to very carefully go through the medication list. Also find out what they received in the last 48, 72 hours. A urinalysis is very, very important. During my training at University of Michigan, they always made us go collect the urine sample ourselves. We'll go to our lab in a nephrology department, spin it, put it on a slide and look at it under a microscope. And we're looking for granular, muddy brown granular cast. Once you see that, we know it's ATN. And you can also see other casts like white cell cast that might be suggestive of AIN, red blood cell cast also too. And if you see like dysmorphic red blood cells, the red blood cells is like they have rabbit ears. That clues you in patient might have a glomerulonephritis. So urinalysis is very, very important. Ultrasound also, if you have ultrasound in the ICU, you can do it or send them to the department. And here, you're just looking for obstruction. If there's hydronephrosis. Now, for those who are very good at POCUS, you can look for venous congestion, but then you need Doppler on your ultrasound. We also try and risk stratify these patients, and this is where something called the furosemide stress test comes in. Now, if you have a patient that's in AKI, not yet on dialysis, not making urine, if there is no contraindication, meaning they are not dehydrated or allergic to loop diuretics, if they are loop naive, meaning they've not been on loop diuretics in the past, you can give them 1 milligram per kilo IV push, or if they've been on loop diuretic, you give 1.5 milligrams per kilo, and you're looking for urine output. If they can make more than 200 mils of urine in the first 2 hours, it kind of gives you a clue that they are less likely to progress to needing dialysis, okay? If they don't make urine at all, it can help you start planning in advance or giving you a clue that this patient has a high chance of progressing to needing dialysis. So you can start trying to make arrangements for renal replacement therapy. Now we have other biomarkers that have been mentioned. You have NGAL, you have KIM1. Now you have one called the TIM2, TIMP, and it stands for tissue inhibitor of metalloproteinases. You also have the insulin-like growth factor binding protein. They come combined together in the lab called the NephroCheck, okay? And they use them mainly for high-risk patients. And the main studies that have been done are in post-cardiovascular surgery patients, because as you can imagine, many of the patients who have all forms of heart surgery, they come out and develop AKI in a day or two, and their mortality morbidity is higher. So this test helps to identify these patients. If you run this test and it's positive, it gives a clue that this patient has a high risk of developing AKI, and you can now initiate what they call the KDIGO bundle, which is you go through the med list immediately, look for nephrotoxic medications, you check their blood pressure, you try and optimize their mean arterial pressure, give them volume if you have to, and just do everything you can to optimize hemodynamics and prevent AKI. Having said that, these biomarkers have only been used in larger university settings and for research purposes. They are not used routinely at the bedside. Everybody is still depending on your serum creatinine and your urine output, unfortunately. As I mentioned, always try and avoid hypotension. In septic shock, we all know how to treat septic shock. You get your MAP at least above 65. If they have underlying chronic hypertension, you might have to use a higher MAP target. If you can't, put in an arterial line, as this will be more accurate. For your vasopressors, what's recommended, first line is norepinephrine. Then you can add vasopressin. If it's inadequate, use epinephrine. Years ago, we used to use dopamine for renal perfusion, no longer the standard of care. And also try and assess your patients to find out if they are fluid responsive. Avoid over-resuscitating them, otherwise they'll become volume overloaded, which is also associated with increased mortality also. Now, fluids and strategies. There has been a lot of debate. What fluid is better? Normal saline or balanced IV fluids, okay? And first study came out in NEGM called the SMART and the SALT ED. So this group, they compared balanced IV fluids, which is mainly lactated ringers and plasma light, versus normal saline. And they looked at which one was associated with a higher mortality. Okay. Now, another group did the same thing, and they came up with two different results. So here's the first group, right? And this was published in 2018. They were able to show that normal saline is associated with increased mortality if we use this as our fluid of choice in the ICU for resuscitation. Also with increased risk of AKI. And they also showed that the patients had higher chloride levels, higher bicarbonate levels also, as you can see, okay? And then here's the odds ratio now. Odds ratio, confidence intervals, as you can see. On your left-hand side, you have balanced crystalloids are better. On the right-hand side, saline is better. And they looked at a subgroup analysis for all the composite outcome for death, new onset renal replacement therapy, or persistent kidney failure. And it was across all groups, medical, cardiac, CNS group, trauma, surgical. And you can see everything falls on the left-hand side, favoring balanced crystalloids, LR. You know, so we all jumped on it. We're also using LR. Then, as I mentioned, the other guy, Finfair, I believe he's from Australia. He's done a lot of trials also. He looked at the same thing also, and he's like, you know what? There's no difference. As you can see, the Kaplan-Meier curve above, looking at saline versus the balanced crystalloids, exactly the same, okay? And subgroup analysis all over the place on both sides. This is saline is better, this is balanced fluids. So bottom line, taper your IV fluids to your patient. However, most of us still try to avoid normal saline when we can. Why? Because you end up with hyperchloremia, non-GAP, metabolic acidosis, and all whatnot, and also just the saline load. If LR is available, most people try to use it. Now, what we know for sure is do not use fluids like hetastat or all those type of IV fluids in the ICU. They have been associated with increased AKI. Now you can use albumin, but albumin is very expensive and it should be tapered only to certain patients. For example, liver cirrhosis patients who are volume overloaded and have very low albumin level. Or after you've done a paracentesis on a patient, because the recommendation is once you've withdrawn more than 6 liters of ascitic fluid, you should give 6 to 8 grams of albumin for each additional liter that you remove. So that's another important indication for albumin in the ICU. Other than that, albumin, saline, albumin, LR, they've all been compared. No mortality benefit. Just that albumin will cost you a whole lot more. Now, nephrotoxin stewardship, always pay attention to your medication list. More and more, we're finding out that this combination of antibiotics that we like to give, vancomycin and zosyn, is associated with AKI, and even more so than vancomycin and cefepime or meropenem. For vancomycin, if you have to use vancomycin, what we do in most hospitals here, we use the AUC, that's the area under the curve, in dosing it. And we're fortunate to have ICU pharmacists. They dose it. So even when I order vancomycin, most times I don't even care what dose is it. I just look for the order that says vancomycin per pharmacy to dose, and I check that box. And then they do the drug levels, they manage it. Sometimes for patients with AKI, all they need is just 1 gram, and then they check a level in 48, 72 hours, just like that. Avoid giving additional nephrotoxins also, like your aminoglycosides, not very common now. The calcineurin inhibitors, we use that mainly in our transplant patients, kidney transplants or heart transplants. We're talking about tacrolimus and the rest of them. They cause AKI by vasoconstriction of the afferent arteriole of the glomerulus, and they might also be nephrotoxic too. Also, IV contrast, if you can't avoid IV contrast, you use it. But the good thing now is that the contrast we're using now, they're mainly very low or smaller agents, and they don't cause contrast-induced AKI like they used to in the past, you know. But if you have to use it, just make sure your patient is adequately volume resuscitated with crystalloids. LR, normal saline, doesn't matter. Just make sure you optimize their volume status before and after giving them contrast. Now for metabolic acidosis, many of our patients, as you know, develop acidosis. Some people are quick to put them on a bicarbonate drip. So a group also did a study on this also. They call that the BICAR ICU trial, and they looked at giving sodium bicarbonate in patients with AKI. And the only patients that actually showed benefit are the subgroup of patients that had stage 2 and stage 3 AKI, or those with pH less than 7.2. They showed a mortality benefit. So if your patient doesn't have severe AKI, no point in giving them a bicarb replacement. Now, the next issue now that we've debated many times in the past, your patient needs kidney replacement therapy. When do you start it? Do I start it early, or do I wait for as long as possible? And many trials were done. You have the ELAINE trial, the AKI trial, IDEAL ICU trial, you have the START trial. All were large center trials, double blind, randomized, controlled, and they found no mortality with starting CRRT or renal replacement therapy early. Recommendation was just look for the standard indications for dialysis. In fact, they found out that in patients, they started dialysis early, they had lots of electrolyte problems, vascular problems, and the groups in which they delayed dialysis, some of those patients actually recovered kidney function and ended up not needing dialysis at all. So just wait and start when it's indicated, like severe hyperkalemia, acidosis, volume overload, or all your other normal indications of dialysis that we know. Renal replacement therapy, you can either do it intermittent hemodialysis if the hemodynamics will support, or continuous replacement therapy if you have it available. We also have SLED, which is just IHD, but we change the settings on SLED and make it as inefficient as possible. You lower your blood flow rates to about 100 to 150 mils per minute. Also lower your dialysate flow rate also too, and then you can do SLED over 8 to 12 hours. CRRT just stands for continuous renal replacement therapy, and IHD. CRRT is a whole different machine. It's not available in all hospitals. It's very expensive also too. But if your patient is in shock, or they have a head bleed, or increased ICP for whatever reason, it's best to use CRRT or SLED. For dosing also, for CRRT is 20 to 25 mils per kilo per hour for CRRT. Increasing the dose has not been shown to be beneficial either. You just end up using more dialysate and be more expensive. And also the filter clots a lot with CRRT, so you have to factor that in. So even if you prescribe 20 to 25 mils per kilo per hour, because the filter keeps clotting, your patient might end up just getting 10 to 15 mils per kilo. And sometimes we actually have to switch to SLED, which is what we had to do about a week ago. I had a patient, he's got liver cirrhosis, and he has heart failure also. His ejection fraction is like 20–25%. He gets routine paracentesis because he's only developing ascites. Unfortunately, he got paracentesis this time and bled in his belly, ended up in the ICU in shock. We put him on CRRT because he was on like 3 pressors. He kept clotting and clotting the filter. These filters are very expensive. Here, insurance will pay. I'm not sure what happens in Nigeria. So we had to switch him to SLED, and he did better with that. Another downside with using the CRRT machine is that you have to anticoagulate them to reduce the clotting of your filter. And some of these patients, you can't use heparin because they have problems with bleeding. Like this patient I just told you about, he bled in his belly, hemoperitoneum, so we couldn't use heparin. So what's actually preferred in large hospitals is citrate. You run the citrate only within the machine. It goes in and then it chelates calcium and prevents the blood from clotting the filter. But it's a very cumbersome process. When I say cumbersome, meaning the ICU nurses need to be trained, okay, because you're giving you're infusing calcium pre-fill. You're giving your citrates, then you're testing your calcium pre-filter and post-filter, and in your return line that is going back to the patient, you have to have a calcium infusion, okay, and you have to be monitoring your ionized calcium levels closely, so you can adjust your calcium chloride infusion that's going in to make sure the patient doesn't get hypo or hypercalcemic. Some patients also develop some complications from this also, but by and large, this is the preferred method for anticoagulation for patients on CRRT, even though it's expensive and requires training, but much less complications than using heparin, as you can imagine, and your filters will last longer. Drug and nutrition, just make sure you dose your drugs optimally, just like I mentioned. Renally adjust your oral anticoagulants, low molecular weight heparin. If you have it available, you can monitor anti-10A for those on heparin drip. Also, some drugs are sequestered in the filter, very lipophilic. You have to watch out for them. Try and optimize your nutrition, avoid overfeeding them. Target your protein about 1 to 3 to 1.5 grams per kilo per day. If they are already on dialysis, you have to increase your protein. If you have the benefit of having a dietitian in the ICU, They can do all these calculations for you. Post AKI follow-up also, if you can follow these patients 7 to 90 days after in the clinic, check them if they have now progressed to acute kidney disease, continue to watch their medications, optimize blood pressure. This is the new group of drugs we're using now, the SGLT2, might be beneficial for some patients also too. In summary, confirm AKI stage, trend the serum creatinine, urine output, do UA microscopy, assess your hemodynamics congestion, target MAP to 65, see if they're fluid responsive, avoid volume overload, consider balanced crystalloids, avoid all nephrotoxics if you can. Also consider the furosemide stress test if they are candidates. Give them sodium bicarbonate replacement if they are candidates, meaning stage 2 or stage 3, or they have severe metabolic acidosis. Start renal replacement therapy for your standard indications. No need starting early, and use optimal dose also. Few things to remember. 1, target your MAP above 65, higher if they have chronic hypertension, no epinephrine, first line, balance crystalloids when feasible, avoid chloride overload, look for nephrotoxins, very important. Many times in the ICU, we're the ones giving these patients Vanc, Zosine, ACE inhibitors, NSAIDs, all those medicines. Don't rush to start kidney replacement therapy. Consider furosemide stress test also too. Here are my references. I can send you some of them. I'm happy to take questions.
Cool.
Thank you very much, Dr. Obiora. That was a very beautiful one. That was that was detailed, and also thank you for keeping to time. So we discussed acute kidney injury in the ICU. You talked about the epidemiology. You gave us the definition, the KDIGO definition. We talked about the common causes of AKI in the ICU, prerenal, intrinsic, and post-renal causes. You taught us about the pathophysiology of sepsis-associated ICU. We talked about diagnosis and workup, risk stratification, how to manage, how to treat ICU, talked about how to treat AKI, talked about the biomarkers that help in identifying patients at risk of AKI, talked about hemodynamic optimization, the different types of fluids, and also the strategies of fluid administration. You mentioned the nephrotoxin stewardship, and also when to start renal replacement therapy in patients with AKI in the ICU. And we now, finally, you talked about what's follow-up, which is very important and which unfortunately most of us do not do post-discharge from the ICU, and which is very important. And the last 2 slides before the references were actually very beautiful ones, where we had the bedside checklist and also 5 things to remember about AKI in the ICU. Once again, thank you very much for that detailed and beautiful lecture. So it's time for questions, comments, and contributions. There are already some questions and comments on the chat box, but I would like anyone who has a question and wants to ask the question directly to please signify by raise of hand so that we can unmute, or you can unmute yourself and then ask the question. Any questions or comments, please, before I start reading the ones in the chat box?
Hello, Dr. Obiora.
Okay.
Yes, right here.
Yes, my name is Dr. Norbert. I'm actually a cardiologist practicing outside the country. And most of my time I spend it in the CCU.
Okay.
which is akin to the ICU.
Yes.
Now, I have this patient that came in about 3 days ago. He's actually 85 years, 85 years old, 85 years old, and he was had ischemic cardiomyopathy. Ejection fraction was about 20-25. When I saw him in the ER, he was not shocked, but he had the typical features of heart failure, shortness of breath, fluid overloaded, and all that. And he was proud to the presentation at the ER. He was on valsartan and all the usual anti-failure medication. Chest X-ray showed minimal congestion and the features of lung fibrosis. At the ER as well, he had elevated INR, was about 5.2, although he was not bleeding. Creatinine was about 185, and I think the WBC was about 10.4, thereabout. Now, my concern was when we shifted him to the ward, I stopped all the nephrotoxic medication and converted valsartan to hydralazine and isosabide. But the very next day, he had hematuria, and then all of a sudden the kidney shut down. So I was really puzzled why they shut in AKI. So I started him on IV fluid, normal saline, and still up to 48 hours, still kidney shut down. We just commenced him on CRRT yesterday because he had now refractory severe metabolic acidosis and severe hyperkalemia. My concern is I'm worried why the sudden kidney shutdown, why the oliguria? Because when we pass catheter, I asked them to pass a catheter because in an elderly gentleman, I was thinking perhaps obstructive uropathy, but catheter was free. And we even had to pass a 3-way catheter to flush the bladder in case there was a blood clot. Still minimal urine output. So I don't know, from your experience, why do you think this kidney shut down? Thank you very much.
Yeah, thank you. That's a very good question. Unfortunately, we have many patients like that. If you don't mind me asking, what country are you practicing?
I'm practicing in Saudi Arabia.
Saudi Arabia, very good. Now, right, there are many reasons why this gentleman could have developed AKI. First of all, he has CKD, right? So poor ejection fraction at baseline, I'm sure this man has cardiorenal syndrome, okay? Now, cardiorenal syndrome, you have organ crosstalk between the heart and the kidneys. Before, we used to think it was just because of poor ejection fraction, poor forward flow to the kidneys, eventually AKI, CKD, but now we're finding out that the kidney is also sending feedback to the heart, and it results in a vicious cycle. Now he decompensated now. So he developed AKI on top of CKD. That decompensation is what I think tipped him over the edge and knocked off whatever functioning renal tubules he had, and now made him go oligoanuric, needing renal replacement therapy. It looks like he's also on some form of anticoagulation because he said his INR was 5. If he's not on anticoagulation, then why is he so?
Actually, he was on warfarin because he had a double mechanical valve replacement.
Okay. So now then you also have to consider other causes, like has he bled in the kidney? That's one. Is he throwing arterioembola into the kidney also too? But by and large, I think the number one cause in this guy is underlying cardiorenal syndrome with CKD. He now has the compensated CHF that has dropped his cardiac output even more, which is what has now led to shutting down of his kidneys. If you guys can, you might want to float a swan, okay? If you float a swan, you can now check and have accurate measurements of his cardiac output index, see what his PA pressures are, and then you can start him on an inotropic agent like dobutamine. Okay? Giving him more saline here, I don't think is going to be helpful because I'm sure his cardiac filling pressures are very, very high. And you would just, you take him even further away from the Starling curve, because your goal now is to try and bring him to the steep portion of the Starling curve so that his cardiac output can increase and perfuse those kidneys. So if you can, flow to swan. If you're not able to flow to swan, you might be able to put in an arterial line, hook that up to a flow track, so you can see, you can still get your cardiac output index, even though swan might be better for him. Thanks.
Thank you very much.
Oh, thank you.
Thank you very much, Dr. Norbert, and also Dr. Obiora for answering that question. So, Mr. President, Dr. Tukwala, your hand is raised. Please proceed with your question. Thank you.
Thank you, Dr. Obiora. It's interesting. I want to ask about fluid use in AKI. How much fluid should we give, irrespective of the cause of AKI in the ICU?
Well,
I don't think in Nigeria we have balance. I don't know which center has balanced crystalloids. We have normal saline and maybe that's lactates.
LR, lactated ringers. We have,
Yeah.
we have lactated ringers, right?
Yeah, we have. Yes, we have.
Yeah. That's a balanced crystalloid. Yeah. Some people have plasma light and all that. So yeah, but if we have LR is a balanced crystalloid. And to answer your question, how much fluid? Always try and assess your patient's volume status and give them only what they need. If you over-resuscitate, they develop volume overload and higher mortality. So if they come in sepsis, give your 30 mils per kilo bolus. And after that, keep assessing for fluid responsiveness in all the ways you and I do in the ICU. You know, heart rate, stroke volume variation, leg raise if they can, and things like that. And only bolus if they need it and if you see a response. So, and every patient is going to be different.
All right, thank you very much.
The reason why I ask the question is that most times when you invite nephrologists to review patients who have AKI, they will look at urine output and then add an additional, based on urine output, they will now say, okay, add so volume to the last output. So that doesn't give a more definite, answer to the question I asked.
No, yeah. So you said they will say, look at the urine output and say, add. Because the problem is that if a patient has developed acute tubular necrosis, meaning the renal tubules have sloughed off, they are not going to make urine while they are in AKI. Regardless of the amount of fluid you give them, they will not make urine until there's re-epithelialization, regeneration, and the renal tubules recover, then they start making urine again. So you can't just keep bolusing if there's no urine output. That's why a lot of these patients eventually develop volume overload. I mean, there are other indications where you check urine output and you replace what you are given, but that's not quite AKI. Maybe, for example, you're doing a bladder irrigation, hematuria, or patients now that are in, have CNS injury and are dumping lots of urine, you have to keep replacing. But if we're talking about AKI, where there's acute tubular necrosis as the reason for why a patient is oliguric or anuric, you cannot keep bolusing IV fluids based on urine output. If the renal tubules are damaged from acute tubular necrosis, they will not make urine regardless of the amount of fluid you give them.
All right, thank you very much again, Dr. Obiora. So Dr. Shotayo, your hand is raised. Please ask your question.
All right, thank you very much, Dr. Obiora, for this well-detailed lecture. Please, I have about 3 questions here. The first is we usually have this scenario with our nephrologists. You have a patient with severe sepsis that is complicated with AKI, and the only sensitive antibiotics sometimes you only have the aminoglycosides are the only sensitive antibiotics. And
sorry,
the
which antibiotic did you
nephrologist will
say?
insist that
Which one? Which antibiotic did you say?
aminoglycosides,
Okay.
aminoglycosides, either
Okay.
gentamicin or amikacin, as the only sensitive antibiotics. And the nephrologist will insist that on no account must we give the patients aminoglycosides. And most of the time we end up losing the patient to septic shock. That's my first question. So what do we do in such scenario that the only sensitive antibiotics are the nephrotoxic ones? So what should we do? So the second question I have here is that we have these patients, of course, with severe sepsis that was complicated with supraventricular tachycardia and AKI. The patient's heart rate was between 140 150. And the nephrologist recommended intravenous metoprolol, which we couldn't get, relatives couldn't get everywhere when they couldn't get the parenteral metoprolol. And of course, the urea and creatinine for this patient were climbing by the hours. And the nephrologist insisted that they wouldn't do dialysis, that he believed that the cause of the renal insults was the SVT, that we should go and address the SVT. So why the renal functions keep declining? So in such situation, what should we do? A patient with severe sepsis, SVT, and AKI, and the nephrologist insists that, okay, there's no need to dialyze. Go and get the SVT treated, even when there are no medications available to treat the SVT parenterally. So what would you advise we do in such case? And the third question is, we usually also have this scenario where you have a patient in polyuric phase of renal failure. You know, their output, daily output, 4 liters, 5 liters per day. And the nephrologist will insist that we should give the previous day output plus insensible loss. So this patient, if we go by that rule, we have to keep giving the patient up to about 6 liters of fluid per day. So, and we keep giving 6 liters, they keep losing 6 liters, and we continue that circle until somebody will have to put their foot down and say, no, we are not replacing previous day anymore. Please, what do you advise we do in that situation for patients with polyuric phase of AKI? Thank you very much, Dr. Obiora.
Okay, thank you. It seems like you and your nephrologists are doing basbos. I don't know, but your first question, the answer is simple. Yes, we don't like aminoglycosides. They are horribly nephrotoxic. We almost never use them here. I don't know when the last time I even saw gentamicin or amikacin. I don't think I've ever prescribed it in like 15, 20 years, you know. However, if that is the only antibiotic your patient is sensitive to, you have to give it. There is no point in a patient dying with 2 functioning kidneys, okay? Better to be alive and be on dialysis than to die with 2 kidneys that are working. So that answer is simple. Your second question, SVT, sepsis, AKI, if there's any indication for dialysis, regardless of etiology, the patient needs to be put on dialysis, you know, while you're still trying to treat whatever the etiology of renal failure was, while you're trying to address your SVT, you know. So just that my only fear is just that I don't know if the patient would have been able to tolerate intermittent hemodialysis with SVT, because I don't know what the blood pressure would have been, because many patients that go into SVT like this, they end up being hypotensive. So patient might not even be able to tolerate dialysis. But if your patient needs dialysis, please go ahead and do it. Doesn't matter if SVT is still present or not. It just makes me sad that family had to run around looking for IV metoprolol, a drug that's very cheap. Your third question is an even more interesting one. It's not often this polyuric phase, we read about it a lot, but it's not often we see it. But you raised a good point. You have to decide when to stop. Otherwise, it will get to a point that the patient is now passing out whatever you're giving him. So what I'll suggest is after you do this for a day or two, start reducing the amount of volume you're giving and monitoring your urine output. And if you're reducing the amount of fluid you're giving and patient is still dumping a lot, that means the patient is still polyuric. But if you reduce your IV fluids you're giving and your urine output also starts dropping, then you're making progress. But if you continue to bolus like that and the renal tubules have recovered, they will just be passing out whatever you're putting in, and you'll just be like a dog chasing your own tail. So you have a good point there. So that's just what I would do. After doing this for a day or two, start reducing your IV fluids and seeing how much the patient is putting out. Thank you.
All right, thank you very much, Dr. Obiora. So we still have a couple of hands raised, but I want to run through the questions we have on the chat box because a few of them they've been there for a while.
Excuse me, moderator.
Yes, please.
I don't know if I can just supply a little information with respect to the SVT.
Okay, that's fine. Please proceed.
Yes, with respect to the SVT in such a scenario, if you cannot lay your hands on metoprolol, although it is quite cheap and sad that it's not available, the very first thing to do with SVT is actually carotid massage. Massage the carotid, and most times it will revert to sinus rhythm. But if that does not work, then the next step is IV adenosine. And then if IV adenosine is not available, at least you can lay your hands on IV amiodarone. Any of these things will work and will correct the SVT. Thank you very much.
All right, thank you very much for that contribution. So on the chat box, we have from Aliyu. Hi there. Okay, the question is, for the FST, are we giving bolus or continuous infusion? Kindly give more explanation on that.
It's a bolus, it's a push. Okay. So yeah, just a push, and then you 1 milligram per kilo if the patient has not been on loop diuretics in the past, or 1.5 milligrams per kilo. So for example, your patient weighs 100 kilos, right? You push 100 milligrams of Lasix, and then you watch your urine output for the next 2 hours. If they put out more than 200 cc's, it gives you a clue that, you know what, there is hope. Means the renal tubules are still intact and are still able to participate, to perform water excretion, reabsorption and excretion. Now, if they don't make that urine, then you know, maybe there's renal tubular necrosis. It might not recover in time. This patient might end up needing dialysis in a few days. Let me start seeing how I can get a hold of a nephrologist to start making arrangements. Or if you don't have dialysis in your hospital, start trying to see how you can send the patient to a hospital where they can do dialysis, so that you don't wait until their potassium is 7 or 8, and they're encephalopathic, then you're struggling to transfer.
All right, thank you very much for that. So the next question is from Dr. Abiola Mafe. Sorry, I didn't get the full meaning of SLED. Thanks for the great delivery.
SLED just stands for slow inefficient dialysis. That's all. Yeah. It's nothing. Yeah, that's all.
Sustained low efficiency dialysis. Yeah. Okay, that's fine. Then Dr. Simeon Olateju, thank you so much, Dr. Obiora Udeozo, for the brilliant presentation. Dr. Norbert, in most patients with distributive septic shock, it is usually quite difficult to achieve and sustain an MAP of greater than 65. Okay, so that is a comment. Yeah. At what dose of NORAD will be advisable to add a second vasoconstrictor, such as vasopressin?
Okay. over here in my ICU, we do it in mics per minute, you know, and it varies. But usually when you start getting to the range of 10 to 15 mics per minute, I add vasopressin. I don't wait until I get to 30.
Right,
and
great.
especially if they're acidotic also, because vasopressors don't work as well in an acidotic environment, but vasopressin does, you know, and it works through a different mechanism also too, the V1 receptors. So if they're acidotic, you're on NOEP 10, 15 mics, you're going within that range, I'll throw in vasopressin.
Okay, fantastic. Thank you. From Tajuddin Fausat, thank you very much for the detailed presentation. My question is, when do we send the patient for dialysis in the ICU? I think you've discussed that over time.
Yeah.
Yes.
Yes, just your standard indications.
Yes.
Yeah.
Sorry,
Then
sir. Sorry. I asked that question. I'm so sorry. Please, why I asked that question is that in the ICU, when we have patients with septic shock, and we see that their kidneys are already shutting down, and we invite the nephrologist, they still parabulate, they tell you do this, and eventually we lose these patients. So that's why I want to know the exact thing. What do we see in this patient that before we insist that we want to send them for dialysis? We are losing those patients in the ICU. That's the reason why I'm asking that question, please.
Yeah.
Thank you.
Yeah, good question. You just have to fall back to your standard indications for dialysis. Back in the day, we used to use AEIOU, you know, acidosis or whatnot. Now we use a gold mark. Okay, it's just a mnemonic. Now, hyperkalemia, volume overload, and the struggle I can sense that's going on here between you and the nephrologist has been the age-old debate of, do patients do better if dialysis is started earlier? You know, and we have done all the studies and we found out that they do not do better if we start earlier. However, just start it based on when you have the standard indications for dialysis. If the potassium is 7, 8, and the nephrologist does not want to do dialysis, that is the problem. If you have severe acidosis, you know, your bicarb is what? 10, 15, pH less than 7.1 or less than 7, they are anuric, not making any urine, or volume overloaded. Those are all indications. You know, yes, you can try bicarbonate drip, tie them over, but if you have those firm indications, dialysis should be started.
All right, thank you very much, Dr. Obiora. And Dr. Fausat, I hope that answers your question.
Yes, sir. Yes, sir. Thank you very much.
Thank you. All right. So from Dr. Stanley, we have, please re-explain one of the targets, CRRT 20 to 25 mils per kg per day. And that's
okay. That's just the dialysis dose that you should aim for when you're giving when your nephrologist or when you're prescribing your CRRT 20 to 25 mils per kilo of your dialysate fluid. I mean, that's a whole conversation in of itself, CRRT dose. And then you also need to try and factor in times that your filter will clot. Because when the filter clots, it might take 2, 3, 4 hours to get a new filter and connect and get the machine going again. Because remember, this 20 to 25 mils per kilo that's prescribed is for a 24-hour period. So if the filter has been down now for 3, 4 hours, they'll end up only getting 15 mils per kilo per hour. So some people actually prescribe a higher dose, maybe even 30, because they know their patients will end up getting 20. But dialysis dose and prescription is a whole conversation on its own, but that's just in a nutshell.
All right, thank you very much. From Dr. Madrabuchi Paul Ufebunam, what is the rate of flow to target during SLED, and what factors determine the duration? And an additional question from him, please explain in more details the correct method of use of citrate as an anticoagulant instead of heparin.
Okay, good question. In SLED duration, normally we do it 8 to 12 hours. The only downside is that you have to have a nurse that is right there who is comfortable managing the SLED. So 8 to 12 hours. And then you drop your blood flow to about 100 to 150 mils per minute. Sometimes maybe 200 mils per minute, your blood flow rate. Then your dialysate flow rate about 100 mils per minute also too. And we run it for about 8 to 12 hours, and you can get significant amount of fluid off, 2 to 3 liters within that period. And then as regards the citrate, the way you do it is that you're infusing citrate into your CRT system, okay? So usually pre-filter, and then it's combining with calcium, now acting as an anticoagulant, right? So it thins the blood going through the filter. So that means now that the blood going back to the patient has low calcium, since the citrate has chelated all that calcium. So when it goes through the filter, you have a line that's going back into the patient. You have to have a stopcock right there where you're infusing calcium chloride back into that line just before it gets back into the patient, into your dialysis line, okay? Because remember, our acute dialysis lines have 2 ports, the drainage port and the return port, blue and red. So yeah, so you have calcium chloride infusing into the return line, and then you have to keep monitoring your ionized calcium levels every hour. And you have to maintain it within the normal range, 0.1, to like what? To like 1, something like that. And then if you notice your ionized calcium level is dropping, you have to reduce the rate of infusion of your citrate. And if your ionized calcium is high, you might need to increase your citrate infusion. So that means you have to have the lab mechanisms for checking ionized calcium every hour. You have to have a well-trained ICU nurse who can keep titrating the drips, because they will call you every hour with this lab result, and then you tell them, drop citrate infusion by so and so cc's, or go up by so and so cc's. And then you also have to watch out for other complications, like something called citrate lock, which is something we can talk about later, where now it ends up chelating all the calcium, and then your ionized calcium is low, but your total calcium is very high, and then you keep giving more and more citrate. That's a problem. They can develop citrate toxicity from that. Yeah.
All right, thank you very much, Dr. Obiora. Our time is fast spent, so I'm just going to run through some of the questions that are still there. So for sepsis, patient with sepsis complicated by AKI requiring, I think we've answered this question. And okay, so what is your maximum allowable dose of noradrenaline infusion before adding vasopressin, which you've talked about? And when do you add adrenaline as a third line?
Now, epi, if you're already on no-epi, 20, 30 mics per minute, you've added vasopressin, you can add epi at that point in time. Especially as some of these patients that have sepsis, they also develop a sepsis cardiomyopathy. But you also have to tailor it per patient. If your patient is tachycardic, epi is probably not a good idea. You might want to do phenylephrine instead. Okay. Yeah. But if like the patient that Dr. Norbert had mentioned, low EF, if this kind of patient is septic now, then epi might be a good idea there as a third agent. Okay. If you're almost max, and usually it's not good to max out one before you go to another. If you're like 15, 20 of no epi, add vasopressin. If you're still going up on no epi, almost max those, add epi also too. Throw in epi. And make sure the acid-base balance is normal, because if they're severely acidotic, your vasopressors won't work. They have an issue binding to the receptor.
All right, thank you. So what is the role of furosemide stress test in determining prognosis of AKI?
We discussed that already. It gives you a clue as to the patients that are going to progress to needing renal replacement therapy.
Yes, therapy, yes.
Yeah. So
Dr. Shotayo is confirming that the previous patient she mentioned was on amiodarone already, okay? And then, so to the previous question about the polyuric patient, if urine output is reduced and the patient is still polyuric, what will be the next step management? Urine output reduced, still polyuric?
No, that's contradictory.
That's contradictory, yes.
Yeah. You can't have low urine output, yeah, so it's contradictory.
Yeah, so it's contradictory. So how do you do the bicarbonate infusion in patients with pH less than 7.2?
Okay, here we have our amps of sodium bicarb have about 50 milliequivalents of sodium bicarbonate in each vial. Okay, yeah. So I try to compose an isotonic fluid. So what I normally do, I tell the pharmacy to add 3 amps of sodium bicarb in a liter of sterile water, you know, or 2 amps in D5 water, 1 liter. Even though if you calculate the serum osmolarity of 2 amps of sodium bicarbonate, that's 100 MEQs in a liter of D5 water, the osmolarity might be about 350, 360 because of the glucose, right? The dextrose. But as soon as you infuse that, glucose is rapidly absorbed and broken down, so it ends up not contributing to serum osmolarity. So that's what I normally do.
Okay, thank you. From Dr. Stella Maris, I believe one of the goals of dialysis is for better clearance. If so, does femoral lines do a better clearance because it's so rampant here? I don't think the line should matter.
Well, you know, no. The best line is the right internal jugular, which is the one I like to put in.
Yeah.
Right IJ, it's a straight shot into the right atrium. You have your tip either at the cavo atrial junction or in the RA. So that one, I like that one. And you get good clearance from there. I mean, you get good clearance also in femoral artery if you don't have a choice, but then high infectious risk. And then patient has to stay in bed for a long time. Also, patient cannot get out of bed in between. Patient has to lay in bed. So first choice, right IJ, right IJ, right IJ.
All right.
Before you go down to the groin.
To the groin, yeah.
Avoid subclavian. Do not do a subclavian.
Okay. Yeah. Great. So we are done with the questions on the chat box. All the others are thank you, and thank you. And yes, the recording will be available for replay. Dr. Paul, your hand is still raised. Do you have, okay, he has put down the hand.
No, I still have a question, please.
Okay, please proceed. Our time is fast spent. Just a few minutes.
Thank you, Dr. Obiora. Please, when I was asking that question concerning citrate, I was actually interested in a patient that has severe sepsis, septic shock, AKI, with coagulopathy, INR of around 3, APTT of around 50. So the nephrologists were debating, should they use heparin during the intermittent dialysis that they want to do? Or do we have alternatives? The patient is already prone to bleeding.
Okay. Are you based in Nigeria?
Yes, I'm based in Nigeria.
And was it for CRT? For
no,
continuous
it was for intermittent dialysis.
So heparin is
in
anticoagulation.
a different facility. The patient needs to be moved out to another facility for the dialysis.
Okay. Well, anticoagulation is not indicated in intermittent hemodialysis because the blood flow rate is very high already, about 350 to 400, even up to 500 or so. So we don't systemically anticoagulate them. So that's number one. Number two, a patient is coagulopathic already. Why are you giving heparin? Patient will just bleed even more. There's no reason for anticoagulation. There are two reasons not to anticoagulate this patient. Yeah, there's no reason.
Okay, thank you.
Thank you, thank you.
All right, so
Thank
final question. Just a minute, please. Just a minute, please, Dr. Daramola. So final question on the chat box. It's still about sodium bicarbonate. The first, what rates do you give sodium bicarbonate constitution? And is there any difference if it's given IV push without diluting in fluids?
You know, when you give it IV push, it only lasts for a very short period. Now remember, that amp of sodium bicarbonate has very high osmolarity. It's about, the osmolarity is about twice that of 3% saline. So you can imagine, almost 600 or so, you know? So, and it only lasts for a very short time, so you don't get good bang for your buck. So it's best to have it as a continuous infusion. Yeah. And in terms of rates, it's all about, because remember, you're giving a sodium load also to your patient, you're giving volume. So you also don't want to overload your patient. So rate will vary from patient to patient based on your patient's volume status and underlying comorbidities. If they have congestive heart failure, EF 20%, you have to be careful.
All right, great. Thank you very much. So Dr. Daramola, please, final question or comment. Thank you.
Thank you very much, Ma, our coordinator. Thank you, Dr. Obiora, for this fantastic lecture. I just wanted to ask your second to the last statement that we shouldn't use subclavian, because in my center, mostly what we do is subclavian. So is there any contraindications to using subclavian? Thank you, sir.
Yes. Subclavian dialysis line. Now, be sure it is not a tunnel line going through like upper chest that is actually in the IJ. Because when you see a tunneled line for long-term hemodialysis, it's actually in the IJ, but people think it's subclavian. Now, the reason why I don't like subclavian lines is that we've noticed during dialysis, the line flaps in the vein, okay? It flaps in the vein, and then it irritates the vessel wall, ends up causing intimal hyperplasia, okay? And if it obstructs the subclavian, it can now long-term cause impedance of blood drainage from, you know, like the head, IVC, and down. It's not a large enough vessel. They can develop SVC syndrome. It's a problem. Only
Thank you
if
very
your
much,
back
sir.
is against the wall. Yeah. Yeah. But IJ femoral.
Okay, for dialysis, I didn't know it was actually restricted to dialysis, as in the talk.
Yeah.
Thank you.
Yeah, he was talking about lines for dialysis. All right, thank you very, very much, Dr. Obiora, for the beautiful delivery and presentation. Thank you for taking time to answer all our questions. It was a very enlightening and educative one. We hope to have you another time talking about something else. Thank you very much once again. Over to you, Mr. President. Thank you.
Thank you very much, Dr. Obiora. You can see that, Dr. Obiora, have you left?
No, I'm still here. I'm still here.
You can see that all the 104 persons who started this meeting have stayed back to listen to you.
Wow.
That is very exciting. It shows how much your discussion has generated, where we intend to start an ICU ward round, and we need more of you to talk to us. As you by sharing your experiences over there with us, it helps us to improve our skill base.
Yes.
So help us as our diasporan representative. I hope you don't forgotten that title. No. To talk, get as many as are willing to talk to us. Very interesting. ICU is just starting. You know, Nigeria, we're still very young. You guys are very advanced. And little things that will enable us, encourage us to practice well and save many lives and actually improve, you know, the mobility that we have, you know, reduce mobility and reduce mortality. That will be very useful for our practice. So thank you very much. Thank you. We are very excited to have you. But at very short notice, you are willing, and then you could even wait till now. You're not in a hurry to leave. I mean, we're very thankful and appreciative of your efforts. Thank you very much. Thank you, everyone. I can see our big Ogas, Dr. Ekuma. So many persons are here on board who are stayed back till now. Thank you. I'm very sorry for Dr. Irene, who actually tried to, who would have been here, but she lost her father-in-law, so she couldn't come in. Thank you, everyone. Good night. Have a nice day. See you the next 2 weeks.
So how do we get the slides?
For those who are our members, they can actually access the slides from our website.
Okay.
So
thank you,
register
sir.
for membership, and then obviously you can access the slide from our website. Thank you and goodbye. Have a nice weekend.
Thank you very much.
Thank you, Mr. President. Thank you,
very
Dr. Obiora.
Thank you.